Boa noite a todos. Eu quero agradecer a presença ilustre hoje do Dr. Joshua Brandstatter. Ele é médico hematologista da Divisão de Hematologia e Oncologia da Universidade da Pensilvânia, nos Estados Unidos. Ele gentilmente agradeceu o nosso convite para participar de uma discussão sobre a doença de Castleman. E então, queria mais uma vez agradecer. Então, daqui a pouco eu vou falar um pouquinho em inglês para ele poder compreender, mas queria deixar aqui à vontade para vocês fazerem perguntas e participarem. A Josi colocou a lista de presença no chat, então quando precisar vocês podem preencher. Eu vou passar a palavra ao Dr. Joshua e mais uma vez eu agradeço aí a participação. Dr. Joshua Brandstatter, thank you very much for accepting our invitation, and we are very glad to have you here talking to us about Castleman disease. Please, you can start your presentation now, and after your presentation, we'll be open for questions and answers. Thank you very much.
Well, thank you so much for the invitation to talk about a subject that I feel very passionately about, which is the care of patients with idiopathic multicentric Castleman disease. Can you hear me all right?
Yeah, yes. Okay. Thank you.
Great. So today I'll speak about its diagnosis and management and describe some of the vanguard research that we've been doing to try to improve patient care over the next few years. So I am a physician scientist at the University of Pennsylvania, and I got conscripted into the fight against this disease by Dr. David Fajgenbaum, who himself developed IMCD during medical school. This disease not only interrupted his medical training, it very nearly cost him his life on several different occasions. His inspiring story changed when he identified a treatment for his disease that has kept him in remission for the past 101 months. Actually, I think a little bit longer. I should update that. He has gone on to co-found the Castleman Disease Collaborative Network and develop many of the consensus recommendations for the diagnosis and treatment of IMCD that I'll describe with you today. He also has a book, Chasing My Cure, that I invite you all to read. Castleman disease is a polyclonal lymphoproliferative disorder characterized by enlarged lymph nodes with particular histopathologic features. It can present as a unicentric disease that involves one lymph node station, or as multicentric disease where patients have generalized adenopathy and clinical and laboratory features of inflammation. Half of all cases of multicentric disease are associated with human herpes virus 8 infection, while the other half are idiopathic. Cases can also be associated with poems from an underlying plasma cell dyscrasia. This talk is going to focus mostly on the diagnosis and management of idiopathic multicentric Castleman disease. First, we must distinguish multicentric from unicentric disease. Unicentric typically only causes localized symptoms due to compression on the adjacent anatomy. Oftentimes it's diagnosed in the cervical region because that's where patients will feel it the most to cause symptoms. It can be cured by complete resection of the involved lymph nodes where feasible. There's an intermediate phenotype called oligocentric or regional Castleman disease that occurs when 2 to 3 local regional lymph node stations are involved, typically in the absence of systemic inflammation that would otherwise meet diagnostic criteria for IMCD. So given the absence of inflammatory signs and symptoms and abnormalities, we think about oligocentric or regional Castleman disease as being biologically more similar to unicentric disease and then treated along a similar paradigm. Multicentric Castleman diagnosis requires not just multifocal adenopathy with Castleman histology, but also laboratory and clinical evidence of systemic inflammation. Importantly, unlike other oncologic diagnoses, the Castleman histology is insufficiently specific to establish a diagnosis by itself. This might be more familiar to rheumatologists that typically have a larger set of criteria that they need to satisfy to establish the diagnosis. But in oncology, this is more unique, whereby typically, if it has the histology, that would be enough to establish a diagnosis. So alternative diagnoses, including rheumatologic and infectious diseases, also must be excluded in order to diagnose a patient with Castleman. This involves careful history taking for arthralgias, morning stiffness, rash, dry eye, mouth, focal infectious symptoms such as cough, diarrhea, or dysuria, followed by laboratory testing as appropriate. A patient with a purely rheumatologic condition, like lupus, can have enlarged lymph nodes that exhibit a Castleman histology, but then their disease would still really be lupus. HHV-associated disease can be excluded by LANA1 immunohistochemical staining of the excised lymph node or whole blood RT-PCR. There are 3 histologic Castleman variants: a hypervascular or hyaline vascular variant that's characterized by these shrunken and atretic germinal centers with expanded mantle zones that appear as concentric rings and prominent follicular dendritic cells within the germinal centers. There's also a plasmacytic histology that involves interfollicular polytypic plasmacytosis with hyperplastic germinal centers, and a mixed histology where you see a little bit of each. Excisional lymph node biopsy of the most hypermetabolic accessible lymph node remains the gold standard, with referral of slides to an experienced Castleman center helpful to more clearly establish the diagnosis. I would say that we would regularly have patients that get biopsies that are either fine needle aspirates or core biopsies that are insufficient to establish the diagnosis, particularly for something as challenging as Castleman disease, where it's not just a monoclonal process. Or patients who have so-called non-diagnostic biopsies, in part because the node that just was the most accessible may not have been, or the most obvious to the patient, may not have actually provided the most diagnostic utility. So particularly for patients who have already had insufficient biopsies, I do recommend getting a PET and going for the most hypermetabolic lymph node on the PET that you can clearly, that you can easily access. Unfortunately, discordant pathologic interpretations are very common in Castleman disease, leading to significant diagnostic delays and confusion. About a quarter of patients submitted to the Castleman Disease Collaborative Network's disease registry have lymph node pathologies that our expert pathologists interpret differently. This heterogeneity of histologic features within lymph nodes, so like one part of the lymph node might look a little bit one way, the other looks a slightly different way. Non-specific histologic diagnostic criteria, so everything I've described about how a Castleman lymph node looks are not terribly specific in them themselves, and very close histomimetics. I was talking earlier about IgG4 related disease, and a number of others that are listed here, all complicate the pathologic diagnosis of this rare disease. Our hope is that greater insight into disease pathogenesis will allow the development of more specific immunohistochemical staining patterns to facilitate the diagnosis. There are 3 subtypes of IMCD. Hafro is the most severe, characterized by thrombocytopenia, anasarca, fever, reticular myelofibrosis, renal dysfunction, and organomegaly. And this is the most fulminant portion of the disease, where patients will present pretty dramatically to the ICU. And probably the biggest driver of morbidity, mortality related to IMCD comes from patients of the Hafro subtype. After establishing a Castleman diagnosis, the severity of the disease should be assessed based on the patient's performance status. Based on the patient's performance status, degree of renal insufficiency, presence of extravascular fluid accumulation, anemia, and involvement of pulmonary disease. This is essential to guide the dosing interval of first-line therapy. So after establishing, so the Castleman disease Collaborative Network recommends IL-6 inhibition as frontline therapy for IMCD. In the United States, siltuximab is the only FDA-approved therapy for this indication, though tocilizumab, which similarly antagonizes the IL-6 pathway, can be used in its place. Patients with severe disease can be treated with an accelerated weekly dosing schedule alongside the administration of high-dose steroids. Otherwise, patients can be treated every 3 weeks, which is the typical way that siltuximab is dosed. Very importantly, patients with severe disease should be monitored clinically every day. Chemotherapy, so oftentimes these patients are already admitted. Chemotherapy should be given to establish disease control should any worsening in clinical status or end organ function occur at any time after starting siltuximab. Roughly a third of patients will respond to IL-6 antagonism, maybe a little bit more. These responders can continue with treatment and are likely to maintain their response long-term. So if anyone responds, they'll likely hold that response as long as they continue to receive IL-6 blockade. Patients who maintain their response for over 6 months can be generally weaned to every 6 week dosing. I wouldn't go beyond every 6 weeks because we do experience patients who have relapses. And certainly we usually do this going from every 3 weeks to every 6 weeks quite gingerly, with kind of slowly spacing them out just to make sure that they don't suffer any relapses from the longer interval between therapy. But patients who are really very stable on their siltuximab, we can feel comfortable starting to space them to every 6 weeks. Unfortunately, the most important for responders is that the necessary duration of therapy is currently unknown, and so we currently recommend lifelong therapy. The majority of patients will be refractory to IL-6 inhibition, though, and there's no standard approach for second-line therapy. For this reason, we strongly recommend referral to an experienced Castleman provider through the Castleman Disease Collaborative Network at diagnosis to help guide therapy in the event of needing to go to a second-line treatment. Rituxan monotherapy is most commonly used in the second line, but we suggest enrollment in a clinical trial where it's available. At the University of Pennsylvania, we have a clinical trial for sirolimus, which is the medication that Dr. Fajgenbaum himself takes, and that trial is also open at the University of Arkansas. There are other case series that you can find in the literature and case reports of oral chemotherapy options and immune modulating therapies that show efficacy, and I'll talk a little bit about some of them in a bit. Similarly, there's no standard approach for chemotherapy selection for severe IMCD. Given the parallels between IMCD and the hyperinflammatory disorder HLH, macrophage activation syndrome, we often model our chemotherapy selection with rituximab, cyclophosphamide, and etoposide, similar to the HLH-94 protocol. We strongly recommend prompt administration of chemotherapy for patients with any clinical worsening after starting IL-6 inhibition. Importantly, IL-6 levels are altered by the use of these drugs. They interfere with the ELISA and cannot be used to assess disease response. While our group has suggested a 7-analyte panel that may predict siltuximab responsiveness, particularly interesting is the CXCL13 levels that seem to be an early predictor of IL-6 responsiveness. Cytokine levels currently play no role in tracking disease response clinically. Particularly for severe disease, clinical status and end organ function are the appropriate markers for disease response. Improvements in platelet counts, symptoms, sedimentation rate, and C-reactive protein can also be observed in responders, followed by eventual regression in the size and metabolic activity of the adenopathy. Building upon translational studies and case reports of the dramatic response to sirolimus, including Dr. Fajgenbaum's own personal experience, as I mentioned, we're currently enrolling patients in a phase 2 open label trial of sirolimus in IMCD patients whose disease did not respond to IL-6 blockade. And since this is sirolimus, we've certainly given it to some patients who maybe don't qualify for the trial, but who need another therapy. So we've been giving it to them sometimes off therapy, excuse me. We've been sometimes giving it to them off trial as well. So it's another consideration for second line or third line therapy for patients who are not responding to cetuximab or rituximab therapy. This will bring me to the larger research efforts that we and others have undertaken to better understand, diagnose, and treat IMCD. So the Castleman Disease Collaborative Network established Accelerate, a natural history registry to combine previously disparate efforts to understand the disease. The international registry includes sites throughout Europe to collect patient data that can then be used to drive new insights into the disease. In the United States, we have a direct-to-patient approach to enrollment. So all patients share their medical data, which is then reviewed by a scientific advisory board based on consensus criteria to confirm the diagnosis. And so this has generated a huge number of insights into the disease that were otherwise difficult to do with rare diseases when we had all these different little silos of people working on this independently. It has really helped in combining our efforts worldwide to understand more about the disease and its natural history. Immunophenotyping and transcriptomic analysis of PBMCs from paired samples of IMCD in flare and remission have suggested a type 1 interferon as a mediator disease flare. This translational work has been coupled with promising case reports suggesting efficacy of ruxolitinib in IMCD patients. Altogether, this makes JAK inhibition a promising new avenue for IMCD patients refractory to IL-6 antagonism. And I can tell you that the Castleman Disease Collaborative Network has been thinking about JAK inhibition as probably one of the most promising future directions for therapy options for Castleman patients, and is hoping to work together with companies to mobilize a JAK inhibition antagonist clinical trial for patients. A proteomic screen of IMCD patient plasma between flare and remission identified CXCL13 as the most upregulated protein in disease flare. This was accompanied by other chemokines, including CCL21. Other work has suggested that improvement in CXCL13 levels can precede clinical responses to cetuximab, as I was mentioning earlier. Excitingly, a patient-derived xenograft mouse model was presented at a recent Castleman symposium replicating features of the disease in immunodeficient mice injected with IMCD lymph node cells. Lethality was observed in these mice, but not mice injected with control lymph nodes from reactive adenopathy. And this lethality could then be rescued with an antibody targeting CXCL13, suggesting another new potential direction for IMCD therapeutics. This is very close to my heart. Recent work has suggested that non-hematopoietic fibroblastic stromal cells in the lymph node might contribute to disease pathogenesis. These cells, these non-hematopoietic fibroblasts that live in the lymph node are a rare population of cells in the lymph node and include these follicular dendritic cells that are histologically aberrant in Castleman, and they can produce a lot of the chemokines seen to be upregulated in IMCD flare, such as CXCL13 and CCL21. Furthermore, others have suggested that non-hematopoietic cells could be clonally expanded in unicentric Castleman. One report even identified a imatinib-sensitive kinase domain PGFR beta mutation in a subset of patients with unicentric Castleman disease. I hope this has proven helpful. In conclusion, I wanted to recommend referral of all patients to the Castleman Disease Collaborative Network, where they can learn more about their illness, be connected with a broader patient community worldwide, and participate in research studies. I'd also like to thank my mentors and collaborators, Drs. David Fajenbaum, Sunita Nasta, Yvonne Milliard, and Sheila Pearson for their help in preparing this talk and all of their work in helping patients with this disease. And I'm happy to spend the remaining time answering any questions that you may have about caring for these patients.
Thank you very much, Dr. Brandstatter. It was an excellent presentation. And Leonardo has one question here. Can you talk about any insights on the use of leniolisib in Castleman disease? Léo, se quiser.
I have no insights into the use, unfortunately, in Castleman disease.
I was thinking about it because this drug is used now to treat APDS patients. So, and it has a very, it's very useful for the control of lymphoproliferation. So some patients may have the benefit on use of this.
I think it's a great idea. I think it's very promising. I think it makes a lot of mechanistic sense in the context of, what's upstream of mTOR, and we know we're, suspicious of an mTOR activation, inappropriate activation, playing a role in the disease because of the clinical responses we see to sirolimus. I think it's I think it makes a lot of sense. The question will be, I think, is it in any way better than sirolimus, or is it really just targeting the same pathway? And so the patients who respond to sirolimus are probably just as likely to respond to that, and ditto the refractory patients, right?
No, maybe somehow, because in our experience, for an example, in treating patients with lymphoproliferation in primary immunodeficiencies, some of them do not respond to sirolimus. Sirolimus is a good drug to treat, for an example, IPEX and others in which the pathway is really related to the mTOR, but in others, especially the APDS syndromes, the leniolisib is much more effective in treating this patient. So that's why I was thinking about this. I have no experience in giving sirolimus to Castleman disease, but maybe we could try on one day.
No, you're exactly spot on. So this is so it all, obviously PI3K is quite, it's quite dirty. It has a lot of different downstream signaling partners, right? So there'll certainly be patients with different diseases who would have responses to a PI3K inhibitor that wouldn't therefore respond to mTOR. But for a patient disease that we know is somewhat mTOR driven, I would suspect they would respond to a PI3K, and that the pathway should be somewhat conserved and similar, so that patients who therefore respond should be also responsive to PI3K. And the refractory patients, it's possible they could also respond to PI3K despite being refractory to mTOR, but they may also turn out to be refractory as well. All this just bellies that we don't understand disease pathogenesis well enough here, right? This is the biggest problem with this disease, right? Everything I say about diagnosis, everything I say about treatment, all comes in this information vacuum we have, and all of the problems that patients experience day in, day out, with this, like, oh, one pathologist told me I had Castleman, another pathologist told me I don't, is because we don't know enough about the disease to say anything more specifically about this is the marker that, of course, if you have this, stain, if this stain on your disease, then for sure you have the disease. And without that, a lot of this is conjecture, right?
Yeah, and do you have any news or something that's going on about biomarkers for the diagnosis?
Yeah, I don't. So like CXCL13 has been one of the most promising things we've had in terms of seeing, with this plasma proteomics screen that I described, right? Like you look at patients in disease flare versus remission, and it goes up pretty impressively during disease flare. The unfortunate aspect of this is, maybe the rheumatologist on the call may know, is that that's not specific.
Okay. Yeah,
it goes up in rheumatologic disease
some other
well.
inflammatory conditions together in the same patient. Maybe it's quite difficult to have a specific biomarker for this in these situations. And another thing that I would like to ask is about the genetics of Castleman disease, because we had a very interesting case when we found not a pathogenic but a variant of uncertain significance in the TNF-AP3 variant in this gene. I don't think it's related, but somehow it may have an impact in some in the pathway of some subtypes of the disorder. I don't think so. I don't know. I don't know anything actually. I'm just questioning what I was thinking.
That's very cool. You're saying you had a patient with multicentric Castleman and you did some next-gen sequencing and you found
Yes,
this mutation?
because we are part of the genome sequencing, rare disorder genome sequencing of these patients. So somehow some patients that, especially Newton, because he see a lot of these patients, he sent to us we are doing the genome sequencing. And I was thinking what we will find and what we can use this data to try to explain something, and also to try to translate it into the daily practices for some.
There have been scattered reports of different findings from similar sort of next-gen sequencing. I think Omar Abdel Wahab's group in Memorial had presented, had like I think they found DMT3A. There've been these scattered reports that suggest it's hard to know in that space, like also whether they were describing CHIP that just happened to be comorbid with their with Castleman disease. And so this has been the problem. There was one group that did a very old technique, this is Humira assay. I don't know if you're familiar. This is how they identified clonality in myeloproliferative neoplasms before we actually knew about JAK or CALR or anything like that. And so just looking at the pattern of X chromosome activation in female patients, and they found no evidence for clonality in multicentric disease, but they did find this to be present in unicentric disease, which was very interesting. And that comes at the same time that they found this, as I think I mentioned, this PGFR beta, this functionally relevant PGFR beta mutation in unicentric disease. So I'd be interested in hearing about all the different reports and of what I think it's great that you're doing this work of looking, and I know we're doing that as well from our government side, like to find different somatic mutations that might be underlying the disease.
Yeah.
But
I wanted you to comment on familial cases. Do you have more than?
Yeah, there are like 2 or 3 families that we've identified, and I honestly don't know what the underlying genetics are, if any, that they've found from these families.
Yeah, because this one that Leonardo is commenting about, actually, we have a large family.
Oh, it's a family?
Yeah.
That's going to be your best, in this way, you're not talking somatic at all, you're talking germline.
Yeah, it's definitely germline mutation, because at this, the older brother, is the first patient I saw, and he had recurrent episodes of macrophage activation syndrome. And we treated him because at that time, like 6 or 7 years ago, sometime like this. And at that time, we did like a short panel because we thought it was somehow some somatic or some mutations related to inborn errors of immunity, not related to anything else. We did an exome because I was at the NIH at that time too, but we haven't found anything. But then after, just now, we found the sister, and we did the diagnosis. Newton did the diagnosis of Castleman, and it's just Castleman. So, and she had like 4 or 5 brothers, sisters, something like this. They had the same phenotype, exactly the same phenotype. But this brother had just recurrent macrophage activation syndrome. So I was wondering if there's any new gene, or someone is studying new gene that we could look after to this family to see if we do have the same, to try to find a monogenic maybe, because it doesn't seem to be something somatic, of course, and also maybe it's something recessive, I think, in the family.
Yeah, I know of maybe 2 or 3 families that have it, and so it's super rare.
And any of those families, because that actually this whole meeting today is based on this family case that we have.
Oh, really?
Yes, because we wanted to learn more about Castleman disease, because we're so intrigued about this. And actually, unfortunately, this first patient that we had died 1 or 2 weeks ago. She had the Tafros, the variant, and was very, very, very severe. And she, after like 5 years of her patient journey to diagnosis, we eventually diagnosed her with Castleman disease, and she was able to start. She received only 1 dose of cetuximab, and then she was admitted to intensive care unit and plaquetopenic and kidney dysfunction. She started hemodialysis, and we could not continue her on cetuximab. So then the only option at that moment was to start sirolimus. So she started sirolimus, and she used it for almost 2 or 3 weeks before she passed away. And what my impression was is that sirolimus was able to reduce the volume, the size of the lymph nodes, but wasn't able to improve the platelet levels nor any difference in the kidney function. So I wanted to know your insights about the sirolimus in patients with Tafro, if you have.
Yeah, so we certainly have patients who responded to sirolimus and do well on that. And we have some patients who don't. I don't know have the bulk, any interval numbers from the trial. Obviously, accrual is always an issue with trial, right? We were so lucky to get this siltuximab.
Yes, because what's very interesting too, because the brother with a recurrent macrophage activation syndrome is being treated with azathioprine since the diagnosis, and is doing pretty well since then. I mean, he had never had anything else. Like it's 4 to 5 years follow-up. So what happened? What's beyond this? I don't know. I don't understand.
For a patient with non-severe disease, right? There's siltuximab, there's rituximab. A lot of patients who do really well with that. Then I think as I was saying, we have a lot of interest in JAK inhibition. And I think that might be something you can think about as well for patients. For anyone who's who has severe disease, I think, I try to make sure we reach for chemo and not hold that back, because I think oftentimes we want to. But it's okay. Like if a patient is having severe disease and you gave them siltuximab, but it's just too late in their process, we like to give chemo then, and this will continue the siltuximab through and not consider them failed on siltuximab yet. Just to give it, and we've had reasonable, obviously it's tough with anyone who's that far along with their disease process, but we've had reasonable success with holding people with chemo for a while. And you can keep giving, RCE, and they'll keep responding to that. And then you can eventually stop and just give their siltuximab a chance to show if they're going to respond to it or not, and then you can move on to the next thing on the line. And as I said, there are also oral chemo regimens that are not too dissimilar from like myeloma-based regimens that seem to do reasonably well in the these are mostly from Chinese cohorts of patients. It's a little bit hard to sometimes extrapolate their data to American patients because they have issues with access to IL-6 antagonism there. So their patients are not really the same as ours. Like they're not necessarily. Some of them are IL-6 responsive patients.
And right now, you cannot predict who is going to respond and who is not. You always start IL-6 inhibition, and then, as you mentioned, like 1/3 of the patients will respond, and the rest probably won't, and you have to do something else to help.
Exactly. As I said, if their disease is so severe and you don't have any breathing room whatsoever, I would go to chemo. If they are on siltuximab and then they get any worse when they have severe disease, I'd go to chemo. And I think that makes, I think RCE is a reasonable chemotherapy, but there's a lot of different things that different people have tried, kind of lymphoma-like regimens that people have used reasonably successfully. But I do like having etoposide on board for these patients because I think there's some advantage there and for these sort of like hyperinflammatory conditions.
Okay, and any ideas about bone marrow transplantation in these patients?
Yeah, I am aware of no case series of it. I think, given where we've been at with therapy, it's tricky because their disease bone marrow transplantation, you usually think about for clonal disorders and getting that GVL effect to remove the residual disease. And it's unfortunately poorly understood what the causes of Castleman disease. So it's hard to say whether, are you talking about allogeneic or auto, I guess.
Mm-hmm.
Whether allogeneic would provide any benefit. In the case of auto, certainly we're now using autos more and more for treating autoimmune conditions, right? Multiple sclerosis now is using a lot of autologous stem cell transplantation with reasonable efficacy. Just not a lot of data in Castleman, and it's still a fairly morbid treatment, and if you can get them responding for siltuximab, rituximab, sirolimus, or ruxolitinib, hopefully you can stave that off. But I'm not aware of any case series of using this.
Thank you very much.
Okay. And you were mentioning about the lymph node excision. So it's are you recommending PET-CT for all patients before choosing which lymph node to remove, or it's not really necessary for all patients?
Yeah, I think sometimes it's a timing call, right? If you have time, right, if the patient is kind of fine, obviously they're not totally fine, they came to you. If you have, kind of time, and depending on what your turnaround is at your institution for getting these things, here we deal with insurance remuneration related issues, right? Getting it pre-approved and blah, 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 blah. But if you have time, then I think it makes sense to get the PET because you can save someone multiple different biopsies that way.
Perfect.
Sometimes it's like, well, the cervical node was what they got diagnosed, was what tipped everyone off that they had a problem, and so they go for that. But then it turns out that there's actually an axe node that's way more hypermetabolic to target, and so that would be the reason to get a PET. With Castleman, you typically see lower volume adenopathy than you would for like a lymphoma patient, and you don't see the same degree of FDG avidity that you would for a lymphoma patient for the most part, right? You're just seeing like SUV maxes of 5 or 6 as opposed to 10 plus or something like that. But it can be informative, and just because I've seen a number of patients who unfortunately have to get multiple different lymph nodes taken out at different places, and it obviously contributes to their frustration, and which is the case, I guess, for all patients, unfortunately, with rare diseases.
And even if it's inguinal or axillary lymph nodes, it doesn't matter if it's hypermetabolic, you would go for that.
Yeah, I agree.
So
if it's accessible and hypermetabolic, think about, of course, the more, unfortunately, we have some cases where it's all abdominal pelvic adenopathy. And in that you're just in a tough situation then, of course. But if you have something that's accessible, you compare everything that's accessible, and I would just target whatever's most hypermetabolic for the patient.
Okay. Thank you very much. And what are the lines of research that you're doing now? Like you're doing basic research and also clinical research.
Yeah. So I do almost exclusively myself. So a lot of the clinical-based research I've been describing has been mostly the efforts of the Castleman Disease Collaborative Network more broadly, and Dr. Fajrenbaum's larger group. I almost exclusively do basic research, laboratory-based translational sciences, where I work with fresh Castleman lymph node tissue that gets donated, and I'm interested in studying the role that the fibroblastic stromal cells may play in disease pathogenesis, because I think we've done a fair bit of characterizing by immunophenotype in genetic studies this atypical lymphoproliferation, the lymphocytes, and I think there's a fair case to be made that the non-hematopoietic cells, though rare, may be contributing to disease pathogenesis. I say this not just because FDCs are histologically aberrant in the disease, right, which is not a specific finding for Castleman and could be correlative and not causative. but also because of the findings with CXCL13 being so high in disease flare, and with the role of, and the suggestion of clonality in unicentric disease in non-hematopoietic cells. So like, as I said, the Humira assay that they did, you know, that's at the same time you do a TCR gene rearrangement, you do a heavy chain rearrangement, nothing, but something's clonal in there that leaves the non-hematopoietic cells. The PGFR beta story as well, they did in situ hybridization where they found enrichment of the PGFR beta mRNA, mutant mRNA in the CD45 negative fraction. And I'm coming from a lab that has been studying the pro-inflammatory role of these cells in the context of graft versus host disease in after allogeneic transplantation. And I am interested in other instances where these cells play a role in human disease. And that's kind of been my into the Castleman world, because I think there's a lot of smoke around these cells. And there's been a lot of use of showing these cells play important roles in host defense, autoimmune model, and largely in mice. With the exception of FDC sarcoma, there hasn't been a lot that shows that they actually play active roles in human disease. And I think this is a good place to start.
Perfect. Thank you very much.
Of course.
Do we have another question from the audience?
Say here, no.
By now, no.
Yeah, but I was intrigued by one of the patients that we diagnosed here with Castleman. She had a severe polyneuropathy, peripheral polyneuropathy, but we couldn't find any evidence of monoclonal component in her. So do you see patients with peripheral polyneuropathy related to the disease as well?
So I will say we've certainly had a couple of patients who have had polyneuropathies without any obvious plasma cell dyscrasia. It's tricky to know what to do with those patients. I think you making sure that you've assessed not only for monoclonal gammopathies and they've had a PET, and because that would really also look for like hidden plasmacytomas or something like that, and that you have checked the VEGF level, because there's a big association with POEMs and VEGF. I also,
but is it?
I also have been getting marrows on these patients a little bit, just to feel really comfortable that we're not missing a plasma cell dyscrasia.
But talking about the VEGF,
sorry,
the VEGF levels, because I've seen that they are elevated in all the patients, even though they didn't have like polyneuropathy. So I'm not sure how to interpret that. If I should be more.
Yeah, you're right. It will be elevated in probably any IMCD patient who's having disease, because it's really just another non-specific inflammatory marker. I just mention it because a lot of people think about it as being a POEMs marker as well. And there's some things that I've seen some providers consider it a specific marker for POEMs. I don't. I think it just goes up with inflammation. So that's why I was just mentioning it on the list. I really just, out of abundance of caution, have been checking marrows on patients to really make sure that there's not anything that, and a PET to make sure there's no plasmacytoma or other underlying plasma cell dyscrasia that I'm missing, and then we can treat their polyneuropathy, symptomatically, or to have a broader thought about what the cause could be of it.
Okay. And the other thing that I wanted to ask, you mentioned that you have the similar histology in patients with lupus. And the thing is that you can have autoimmune phenomena in Castleman disease. So many times if you look for all the criteria for lupus, you can fulfill the criteria and label them as having a lupus diagnosis, and maybe they are not actually lupus, they are Castleman. This is what happened with one of our patients here. So your cohort of patients, how were they like misdiagnosed or previously diagnosed before receiving the Castleman diagnosis?
Yeah, the catchphrase in oncology is, and this will not translate well, is the tissue is the issue, right? And so it's always important for particularly if for an oncology office, I mentioned that that's not just because you have your biopsy, you haven't finished your work here in terms of establishing a diagnosis. And I think it gets at what the larger clinical picture for the patient is. You know, I literally treated a patient who told me they had Castleman disease. They had bilateral cervical adenopathy. They had a very clear Castleman histology, but their symptoms were dry mouth, dry eyes. You know, it was a burning mouth syndrome, and you know, their local provider was ready to start them on siltuximab, and you know, the ANA, SSA, SSB were screamingly positive. And so that's obviously an extreme example, but you know, if the patient's presenting and you know, you have a consistent biopsy with lupus nephritis, and you treat the patient in front of you and not just look at the histology and think you're working. But you're right, there can be a situation where it can get gray.
But I mean, you want to say that Castleman can be a phenomenon sometimes, not the disease. Yes,
exactly. That's an epiphenomenon. I would think about it as not being, in this case, too different from any other reactive histology of lymphadenopathy. It's the immune system disordered in some way, right? And this all comes to the fact that whether you're talking about autoimmune conditions or Castleman, there's something wrong going on in the germinal center. Whether that's because follicular dendritic cells are providing inappropriate thing, but that's really where and that's why you were talking about the association of Castleman with, you know, so that's predominantly with unicentric disease in kids who get awful pemphigus or bronchiolitis obliterans, where you know, that can be the biggest driver of mortality associated with unicentric disease. Of course, the other being it's in a really bad spot. And again, it's all probably the underlying problem is something going on with the germinal center. And similar, you can get autoimmune phenomenon with FDC sarcoma as well. Again, it's all because, you know, there's a problem with the germinal center response.
Right.
Interesting, because some hematologists in Brazil don't even believe that Castleman existed. So somehow,
well, that's okay, because in the United States, I could surprise you. I could say similar things. We get a lot of different.
Like if you tell them like there is a phenomena that may be called Castleman, so they say it doesn't exist at all. It's it's very interesting. I mean, I'm thinking now of about the physiopathology. I'm not much more, but I like the lab, the basic research too. I work with an autoinflammatory disease. I don't work with Castleman either. So I was thinking about the inflammatory phenotype. I mean, what may be activated there, and I was thinking like if it's a phenomenon, so it's something that triggers there. There's something triggering. So what triggers? So that's what I was thinking. But thank you very much. It's very insightful.
Yes, no, I really appreciate the chance to talk about Castleman, because as I was saying, in the United States, we also have a lot of these funny ideas, and I tell patients all the time, you will have wonderful, perfectly, you know, first-rate hematologist oncologists who will never see this disease in their life. And I'm sure as you treat enough rare diseases, right, you have the same thing going on, and they're fine. This is where you need to be, because you know, we do purple zebras all the time.
Yes, that's very much like that.
And I'd be interested in talking more about your family as well, and maybe like more like a informal research capacity, and talking about brainstorming ideas.
Okay.
Yeah, if you have any, I mean, if there's anyone working on or found a gene, a candidate gene, for an example, and if you want to confirm, we have samples here for all the family stored, and also the genome sequence, all the genomic sequence of all these patients. So if you have an idea of something, and if you need a sample to confirm, we are we can do it, and we can also do some functional assays here to confirm, because we are not, I don't know if you're aware, but in Brazil to send samples abroad, it's quite complicated because we need the permission of the Pope. So, maybe really it's quite complicated here, but we can do many things in our lab. So, I mean, I'm very curious to know which gene is involved in this family, because I've been studying these patients since many years ago, and I was always.
Have you just done a whole? Have you done whole exome?
Genome.
Whole genome.
The whole genome.
Genome, yeah, of all the family.
And that's where you came up with this. What you said it was TNF, which family member?
TNF-AP3, A20. You know the A20 protein related to this monogenic Behçet disease? Yes, this is the gene, but I don't think it's related to the phenotype, of course. But we are waiting for the genome sequencing of the other members to put them together to analyze to see if we found something there. But probably, based on in my experience with other families here in Brazil, when we do the trio, we found many 200, 300 variants sometimes. So I don't think it's going to be the end of this history. So maybe we need to look to other families to try to find something similar. Yeah. So we are open. If you want to use our family, feel free.
Yeah, we'll have to just talk about some ideas.
Yeah, and actually the family is because it seems to be like a dominant disease. So maybe the ones that the children that did not start to develop symptoms may in the future. So if you find something, and treat early and prevent. Yeah,
exactly. And that's, I think, what's been so amazing about the way that the CDCN is set up here is incredible, because it's a patient run, all right. Dr. David is a patient himself, and we have I don't know if you have similar opportunities with your disease, with your rare disease communities, to like have them all the patients come for a summit, and they're literally spending the morning helping give blood samples, and then they get to dictate also what they think are the priority research priorities ought to be, right? What are we not addressing effectively? It's such a I think a cool model for how a disease-based organization should be run.
I don't think I thought we don't have any other questions.
Any additional question? No.
Yeah. Okay.
But I wanted to end like just thank you once again for your excellent presentation, and this discussion was very, very, very helpful to us. And I hope you can join us in the future again. So thank you very much again.
Yes, this has been a really great conversation about this disease and how we should be treating it and thinking about it from a research perspective too. So hopefully we'll get a good collaboration out of this.
Sure. Thank you very much.
Right.
And have a good night.
Yes,
pessoal, então, obrigado aí pela participação. Não esqueçam de assinar a lista de presença que está ali no chat que a Joyce colocou. E agradeço mais uma vez a participação de todos. Uma boa noite e até a próxima.
Thank you. Bye bye.
Bye bye. Thank you.